Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in the Houston area, and the focus of this presentation is ACC AHA 2021 guidelines for chest pain evaluation and management. And this particular focus presentation is on intermediate risk group. I did a whole presentation on the entire ACC AHA 2021 guidelines on chest pain, which is about 50 minutes long. It comprehensively covers everything in that article. But this presentation is focused mainly on the intermediate group, because the low risk group patients are generally evaluated by the emergency department physician and disposed based upon their findings. The high risk patients are, which are pretty obvious, they have ischemic heart disease, and it involves multidisciplinary approach to manage those patients. As a practicing cardiologist or a country cardiologist, we need to be aware of the intermediate group, which I'm going to explain which that comprises and how do we deal with these patients when they present with the chest pain with history of no known coronary artery disease in the past. So let us begin with the feature presentation. This presentation is based on the 2021 ACC AHA chest pain guidelines published in circulation in November 2021. If you would like to reference this one, you can just Google the title and download this PDF file, which is free, and then you can use this as a guide for the next 5 years until they come up with the next series of guidelines for managing patients with chest pain. So, what is an intermediate risk group? First, we need to define what is the population we are dealing with. The intermediate risk group is someone who has a heart score of 4 to 6. You just have to learn what these TIMI score of 2 to 4 or European Society of Cardiology based upon the high sensitivity troponin levels, which the initial one is between low and high, or 1 to 2 hour change is between low and high. So they go from very low to high normal. What do you do with these patients? Because there has been a change in the troponin level. How do you decide what needs to be done next? That's what we're going to be covering. So let us translate this mystery into a clinical scenario of who are these intermediate risk patients we are talking about. Based upon 40 years of my clinical experience, I can tell you these are patients who are generally over the age of 45 years, patients who have risk factors like hypertension, diabetes, smoking, obesity, or family history. The people who have borderline EKGs like left ventricular hypertrophy from hypertension, or patients who have non-specific STT changes. And we talked about the troponin levels already in the previous slide. So if we are presented with a patient of this category and they have no known history of coronary artery disease in the past, how do we evaluate these patients? To do that, this 2021 ACC/AHA guideline has produced a very beautiful flowchart which looks very complex, but don't get scared. I'm going to break this down into simple parts so that by the end of this presentation, you will be more knowledgeable about dealing with these patients with confidence based upon clinical guidelines and based upon studies that are validated by the ACC and AHA. So let us begin from the top here. Acute chest pain, intermediate risk group with no known coronary artery disease. The first determination we have to establish is, did this patient have a prior cardiovascular testing, such as a stress test? If the answer is yes, then we follow this pathway. If they had no prior cardiovascular testing, stress test, or a myocardial perfusion imaging, then we follow this pathway. So let us just forget the right half of the chart and just focus on the left half of this chart and try to simplify things from a clinical perspective, because I have been a clinical cardiologist and my focus is on what do we do in the emergency department when we have a patient of this presentation based upon their existing symptomatology and pre-existing conditions. Here I have expanded the left half of the chart. From a clinical perspective, I can tell you what we need to first establish is, does this patient have obstructive coronary artery disease? Number one. Number two, we have to establish what is the functional significance of this coronary obstruction, because patients can have ischemic symptoms with non-obstructive coronary artery disease, or they may have obstructive coronary artery disease with no symptomatology. So it is very important to establish the anatomy and also the functional significance of any coronary artery stenosis. In order to do that, we look at the prior test that was done. If the stress test was negative, here it says discharge, but I'm not sure I would just discharge them from the emergency room just based on the test, because as I said, patients can have ischemia with a negative stress test if they have coronary artery spasm, or could be pericarditis. Anyway, if the prior test was inconclusive or mildly abnormal, then they recommend coronary CT angiography. And based upon the coronary CT angiography, if the coronary CT angiogram reveals less than 50% stenosis, consider this as non-obstructive coronary artery disease and follow that pathway. But more importantly, we need to ascertain as to whether this stenosis between 40 and 90%, that's what the guidelines call for. We need to do FFR-CT, that is fractional flow reserve based on CT angiography, or a stress testing using myocardial perfusion imaging such as SPECT, PET, or CMR. If you have already done a CT angiogram and you find out they have a lesion between 40 and 70% and you're not sure what is the functional significance of that, then we can do the FFR-CT. However, in this mid-range group between 40 and 70, where we need the answer most definitively, that's where the sensitivity and the negative predictive value of this FFR-CT is the lowest. In the extremes, critical stenosis versus normal coronary artery, the FFR-CT is excellent. But in the mid-range, that's where we need the answer most critically. That's where the FFR-CT is not so much reliable. The sensitivity is like 65%. In addition to that, we also have to consider the presence of calcium, adequate heart rate, and additional cost. In one of the presentations, I saw the cost of getting the FFR from your CT angiogram is like 3 to 4 times that of the cost of just CT angiogram. So you need to consider the costs and the time involved. Surprisingly, in 2020 presentation which I watched, which was from the medical center here in Houston, there's only one center that does this FFR calculation, and you have to wait 6 to 8 hours. On top of that, you're going to need expert interpreters to ascertain as the significance of those numbers. Assuming that you have bypassed all these hurdles and you see the FFR-CT results as less than 0.8, which suggests moderate to severe ischemia, or greater than 0.8, which suggests the stenosis is not functionally critical. If the stenosis is not critical, we follow the guideline-directed medical therapy and send the patient home. On the other hand, if the FFR-CT is showing less than 0.8, the patient should undergo invasive coronary angiography, or IC, Whereas if they have greater than 50%, so this is in the group of patients who had prior testing. So let's look at the right half of the first chart, the right half of this chart, which I was showing you earlier, that is if they had no prior testing whatsoever. So they gave us an option of FFRCT or stress testing. The advantage of myocardial perfusion imaging is you can look at it from a different perspective in terms of the region of the myocardial ischemia, the amount of the myocardium at jeopardy, the overall left ventricular size, and overall left ventricular function. If the degree of ischemia is less than 10% of the myocardium involved, less than 10% of the myocardium, then those patients can be treated medically based upon the long-term follow-up of nuclear study patients. If they have like 15-20% or bigger reversible ischemia, then I think it is reasonable to do invasive coronary angiography. So that is from a myocardial perfusion testing, either based on SPECT, PET, or CMR, then that will help us to determine that. Whereas if we do a PET, we can also measure the coronary FFR. Now let's look at the right half of this chart, which is even simpler. It looks complex, but it is much simpler, and see what we can come up with. Again, whatever you do, the underlying questions are, does this patient have obstructive coronary artery disease? And if so, what is the functional significance of this stenosis? And again, they recommend CCTA, that coronary CTA. If it's less than 50%, then they can go home. If it's inconclusive stenosis or greater than 50% stenosis, then we can do FFR, or we can do myocardial perfusion imaging using different modalities. And again, if the FFR is less than 8, they go for invasive angiography. If it's greater than 0.8, which suggests the stenosis is not significant, they can be treated medically and discharged. However, if the obstruction is greater than 50% and we have a patient with recurrent chest pains and multiple risk factors, then the option would be to go for coronary angiography. So even though the chart looks very complex, we had to simplify as what is it that we are trying to find out, and second question is what is it that we are trying to determine. First, we want to find out, does this patient have ischemic heart disease? The second point is, does this patient have significant reversible myocardial ischemia as a cause for chest pain? If so, would a coronary angiogram and a coronary intervention help us to resolve that question? So ladies and gentlemen, this is a quick synopsis of the most challenging group of patients. The most challenging group of patients, namely the intermediate group, where we need to simplify things and decide upon how we triage these patients. I hope this has been useful to you. This is something which I have used in my practice, not necessarily FFRCT, but myocardial perfusion imaging all these years. Now FFRCT is an additional option that is available, but again, it depends upon whether your center has a high quality rapid CT with expert interpretations and excellent techniques, so you don't get a borderline report on every test that is done. Thank you so much for watching, and please do watch our ACC AHA guidelines on not only chest pain but also on coronary interventions through catheterization and stenting or through bypass surgery. And I have another presentation on ACCHA guidelines on heart failure management. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel, and I will see you in the next presentation.